Hello class, welcome to the recorded lecture on Chapter 24, Trauma Overview. After students complete this chapter and the related coursework, they will have an understanding of the basic concepts of energy and its effect on the human body, the general injury patterns associated with different types of impacts, falls, and penetrating trauma, and the basic application of laws of physics on the assessment of trauma victims. Students will begin to demonstrate critical thinking in making predictions of injuries and adjusting index of suspicion based on the analysis of evidence gathered in the scene size-up simulations. Students will also understand some common injury patterns to major body systems. Introduction. For people younger than age 44 years, traumatic injuries are the leading cause of death in the United States. Proper pre-hospital evaluation and care can reduce suffering, long-term disability, and death from trauma. Trauma emergencies occur as a result of physical forces applied to the body. Medical emergencies occur from an illness or condition not caused by an outside force. Traumatic injuries may be caused by an underlying medical conditions or medical illness may result from recent or remote traumatic injuries. Evaluation of the MOI for the trauma patient will provide you with an index of suspicion for different types of serious and/or life-threatening underlying injuries. Index of suspicion is your awareness and concern for potentially serious underlying and unseen injuries. Energy and trauma. Traumatic injury occurs when the body's tissues are exposed to energy levels beyond their tolerance. Mechanism of injury is the way traumatic injuries occur. Describes the forces of energy transmission acting on the body that cause injury. Three concepts of energy are typically associated with injury: potential energy, kinetic energy, energy of work. Energy can be neither created nor destroyed, but can only be converted or transformed. Work is defined as a force acting over a distance. Forces that bend, pull, or compress tissues beyond their inherent limits result in the work that causes injury. Kinetic energy is the energy of a moving object. Reflects the relationship between mass, or weight, of an object and the velocity, its speed, at which it is traveling. Kinetic energy equals half mass times velocity squared. According to the equation of kinetic energy, the energy that is available to cause injury doubles when an object's weight doubles, but quadruples when its speed doubles. Potential energy is the product of mass, weight, force of gravity, and height, mostly associated with the energy of falling objects. Mechanism of injury profiles. Different types of MEOIs will produce many types of injuries. Non-significant MOIs, injuries to an isolated body part, a fall without the loss of consciousness. Significant MOIs, injury to more than one body system, multi-system trauma, falls from heights, motor vehicle and motorcycle crashes, car versus pedestrian, bicycle or motorcycle, gunshot wounds, stabbings. Blunt and penetrating trauma. Traumatic injuries can be divided into two separate categories: blunt trauma and penetrating trauma. Blunt trauma is a result of a force to the body that causes injury without penetrating the soft tissue or internal organs and cavities. Penetrating trauma causes injury by objects that primarily pierce and penetrate the surface of the body and cause damage to soft tissues, internal organs, and body cavities. Either type may occur from a variety of MEOIs. It is important to consider unseen as well as visible, obvious injuries with either type of trauma. Blunt trauma. Blunt trauma results from an object making contact with the body. Motor vehicle crashes and falls are the most common MOIs. Be alert to skin discoloration and pain. These may be the only signs of blunt trauma. Maintain a high index of suspicion for hidden injuries. Vehicular crashes. Motor vehicle crashes are classified as frontal, head-on, rear end, lateral, T-bone, rollovers, rotational, spins. The principal difference is the direction of the force of impact. A crash typically consists of 3 collisions: car against another car, tree, or object. Damage to the car does not directly affect patient care but does provide information about the severity of the collision. By assessing the vehicle that has crashed, you can often determine the MOI. Passenger against the interior of the car. Kinetic energy produced by the passenger's mass and velocity is converted into the work of stopping his or her body. Common passenger injuries include lower extremity fractures, rib fractures, and head trauma. Passenger's internal organs against the solid structures of the body. Internal injuries may not be as obvious as external injuries, but they are often the most life-threatening. Significant MOIs are suggested by death of an occupant in the vehicle, severe deformity of vehicle or intrusion into the vehicle, moderate intrusion from a lateral accident, severe damage from the rear, crashes in which rotation is involved, ejection from the vehicle. Frontal crashes. Evaluate the supplemental restraint system. Determine whether the passenger was restrained by a full and properly applied 3-point restraint. Determine whether the airbag was deployed. Seatbelts and airbags are effective in preventing a second collision inside the motor vehicle. Seatbelts may decrease the severity of the third collision. Airbags decrease the severity of deceleration injuries and decrease injury to the chest, face, and head. Despite airbags, suspect injuries to extremities resulting from the second collision, internal organs resulting from the third collision. Children shorter than 4'9" should ride in the rear seat. In a pickup truck or single-seated vehicle, the airbag should be turned off. Remember that if the airbag did not inflate during the accident, it may deploy during extrication. Remember that supplemental restraint systems can cause harm whether they are used properly or improperly. Hip dislocations may result if seatbelts are worn too low. Internal injuries can occur when the belt is worn too high. Lumbar spine fractures are also possible, particularly in children and older patients. Passengers riding in vehicles equipped with airbags but not wearing seatbelts are often thrown forward and come into contact with the airbag and/or the doors at the time of deployment. Look for contact points between the patient and the vehicle as you perform a simple, quick evaluation of the interior of the vehicle. Rear end crashes. Rear end impacts cause whiplash-type injuries, particularly in the absence of an appropriately placed headrest. As the body is propelled forward, the head and neck are left behind. The cervical spine and surrounding area may be injured. Acceleration type injury to the brain is possible. Third collision of the brain within the skull. Lateral crashes. Lateral or side impacts are very common cause of death associated with motor vehicle crashes. A vehicle struck from the side is usually struck above its center of gravity, begins to rock away from the side impact. This results in the passenger sustaining a lateral whiplash injury. If there is substantial intrusion into the passenger compartment, suspect lateral chest and abdominal injuries on the side of impact, possible fractures of the lower extremities, pelvis, and ribs, organ damage from the third collision. Approximately 25% of all severe injuries to the aorta that occur in motor vehicle crashes are a result of lateral collisions. Rollover crashes. Large trucks and sport utility vehicles are prone to rollovers because of their high center of gravity. Injuries depend on whether the passenger was restrained. The most unpredictable types of injuries are caused by rollover crashes in which a passenger is unrestrained. The most common life-threatening event in a rollover is ejection or partial ejection of the passenger from the vehicle. Even when restrained, passengers can sustain severe injuries. Rotational crashes. Rotational crashes or spins are conceptually similar to rollovers. The rotation of the vehicle as it spins provides opportunity for the vehicle to strike objects such as utility poles. Car versus pedestrian. Injuries are often graphic and apparent. There can also be serious unseen injuries to underlying body systems. You must maintain a high index of suspicion for unseen injuries. You should determine the speed of the vehicle, whether the patient was thrown through the air and at what distance, surface the patient landed on, whether the patient was struck and pulled under the vehicle. Evaluate the vehicle that struck the patient for structural damage. ALS backup should be summoned for any patients who have or are thought to have sustained a significant MOI. Car versus bicycle. Evaluate the MOI in much of the same manner as car versus pedestrian crashes. Evaluate damage to and the position of the bicycle. If the patient was wearing a helmet, inspect it for damage. Presume that the patient has sustained an injury to the spinal cord, column, or spinal cord, until proven otherwise at the hospital. Spinal stabilization must be initiated and maintained during the encounter. Car versus motorcycle. Protection is from the helmet. Does not protect against severe cervical injury. Leather or abrasion-resistant clothing will protect against road abrasion but not against blunt trauma from secondary impacts. Boots. Collisions usually occur against larger vehicles or stationary objects. When assessing the scene of a motorcycle crash, look for deformity of the motorcycle, side of most damage, distance of skid in the road, deformity of stationary objects or other vehicles, extent and location of deformity in the helmet. There are 4 types of motorcycle impacts. Head-on crash. The motorcycle strikes another object and stops its forward motion while the rider continues his or her forward motion until stopped by an outside force. Angular crash. The motorcycle strikes an object or another vehicle at an angle so that the rider sustains direct crushing injuries to the lower extremities between the object and the motorcycle. Ejection. The rider will travel at a high speed until stopped by a stationary object, another vehicle, or road drag. Severe abrasion injuries, or road rash. down to the bone can occur with drag. Controlled crash. A technique used to separate the rider from the body of the motorcycle and the object to be hit is referred to as laying the bike down. Falls. The injury potential of a fall is related to the height from which the patient fell. The greater the height of the fall, the greater the potential for injury. A fall from more than 20 feet, 6 meters, is considered significant. Internal injuries pose the greatest threat to life. Patients who fall and land on their feet may have less severe internal injuries because their legs have absorbed much of the energy of the fall. However, they may have very serious injuries to the lower extremities and pelvic and spinal injuries. Take into account the height of the fall, the type of surface struck, the part of the body that hit first, followed by the path of energy displacement. Penetrating trauma. Penetrating trauma is the second leading cause of trauma death in the United States after blunt trauma. Low energy penetrating trauma may be caused by accidentally by impalement, intentionally by a knife, ice pick, or other weapon. Many times it is difficult to determine entrance and exit wounds from projectiles in the pre-hospital setting. Determine the number of penetrating injuries. Combine that information with the important things you already know about the potential pathway of penetrating projectiles. With low energy penetrations, injuries are caused by sharp edges of the object moving through the body and are therefore close to the object's path. Knives may have been deliberately moved around internally, causing more damage than the external wound suggests. Try to determine the length of the penetrating object. In medium and high velocity speed penetrating trauma, the path of the projectile, usually a bullet, may not be easy to predict. The bullet may flatten out, tumble, or even ricochet within the body before exiting. The path the projectile takes is its trajectory. Fragmentation will increase damage. The bullet's speed is another factor in the resulting injury pattern. Cavitation results from rapid changes in tissue and fluid pressure that occur with the passage of a projectile. Can result in serious injury to internal organs distant to the actual path of the bullet. Temporary cavitation injuries result from a stretching of the tissues that occurs with pressure changes. Permanent cavitation injury results closer to the bullet path and remains after the projectile has passed through the tissue. The relationship between distance and severity of the injury varies depending on the type of weapon involved. Air resistance, often referred to as drag, slows the projectile, decreasing the path of penetration and energy of the projectile, and thus reducing the damage to the tissues. The area that is damaged by medium and high velocity projectiles is typically many times larger than the diameter of the projectile itself. This is one reason that exit wounds are often many times larger than entrance wounds. The energy available for a bullet to cause damage is more a fraction of its speed than its mass. Any information regarding the type of weapon that was used should be relayed to medical control. The table on this slide shows signs of developing problems in traumatic patients. Blast injuries. Although most commonly associated with military conflict, blast injuries are also seen in civilian practice in mines, shipyards, chemical plants, and in association with terrorist activities. The figure on this slide shows the 4 mechanisms of blast injury. People who are injured in explosions may be injured by 4 different mechanisms. Primary blast injuries, those are due entirely to the blast itself. Damage to the body is caused by the pressure wave generated by the explosion. Secondary blast injuries. Damage to the body results from being struck by flying debris. Tertiary blast injuries. The victim is hurled by the force of the explosion against a stationary object. Quaternary miscellaneous blast injuries. Burns from hot gases or fires started by the blast. Respiratory injury from inhaling toxic gases. Crush injury from the collapse of the buildings. Suffocation, poisoning, and other medical emergencies. Contamination of wounds from environmental, chemical, or toxic substances. Most patients who survive an explosion will have some combination of the 4 types of injuries mentioned. Tissues at risk. Organs that contain air, such as the middle ear, lung, or gastrointestinal tract, are most susceptible to pressure changes. Junctions between tissues of different densities are exposed areas such as head and neck tissues are prone to injury as well. The ear is the most sensitive to blast injuries. The tympanotic membrane evolved to detect minor changes in pressure and will rupture at pressures of 5 to 7 pounds per square inch above atmospheric pressure. Pulmonary blast injuries are defined as pulmonary trauma that results from short-range exposure to the detonation of explosives. Primary blast injury is often characterized by the lack of external visible injuries. Pneumothorax is a common injury and may require emergency decompression in the field. Pulmonary edema may ensue rapidly. One of the most concerning pulmonary blast injuries is the arterial air embolism, which occurs on the alveoli disruption with subsequent air embolism into the pulmonary vasculature. This can produce disturbances in vision, changes in behavior, changes in state of consciousness, and a variety of other neurologic signs. Solid organs are relatively protected from shockwave injuries, but may be injured by secondary missiles or a hurled body. Neurologic injuries and head trauma are the most common causes of death from blast injuries. Subcunoid and subdural hematomas are often seen. Bradycardia and hypertension are common. Extremity injuries, including traumatic amputations, are common. Multi-system trauma. Multi-system trauma involves more than one body system. Head and spinal trauma, chest and abdominal trauma, chest and multiple extremity trauma. You must alert medical control and transport rapidly. Golden principles of pre-hospital trauma care. Your main priority is to ensure your safety, safety of your crew, safety of the patient. Determine the need for additional personnel or equipment. Evaluate the MOI. Identify and manage life threats. Then focus on patient care. Assess and manage the airway. Ensure that the basic shock therapy is completed. Control bleeding. Consider using a tourniquet. Protect the spine and proceed with spinal immobilization if indicated. Transport the patient immediately to an appropriate facility. In most patients with multi-system trauma, definitive care requires surgical intervention. On-scene time should be limited to 10 minutes or less. During transport, obtain a sample history and complete a secondary assessment. Consider ALS intercept and/or air medical transportation. Patient assessment. Patient assessment consists of scene size-up, primary assessment, history taking, secondary assessment, and reassessment. When you are caring for a patient who has experienced a significant MOI and the patient is considered to be in serious or critical condition, you should rapidly perform a physical examination. With a patient who has experienced a non-significant MOI, focus on the chief complaint while assessing the patient as a whole. Injuries to the head. Disability and unseen injury to the brain may occur. Bleeding and swelling inside the skull is often life-threatening. Include frequent neurologic examinations in your assessment. Some patients will not have obvious signs and symptoms until minutes or hours after the injury has occurred. Injuries to the neck and throat. This is an area of serious and deadly injuries. The trachea may become torn or swell. Airway problems may result that could quickly become serious life threats. Your assessment must include frequent physical examinations looking for DCAP BTLS in the neck region. DCAP BTLS stands for deformities, contusion, abrasion, puncture or penetrating injury, burns, tenderness, lacerations, and swelling. Also assess the jugular vein distension or tracheal deviation. Swelling may prevent blood flow to the brain and cause injury to the central nervous system. A penetrating injury may result in an air embolism. Use occlusive dressings to prevent this. A crushing injury to the upper part of the neck may also cause the cartilages of the upper airway and larynx to fracture. Injuries to the chest. The chest contains the heart, lungs, and large blood vessels. Many life-threatening injuries may occur. Broken ribs may hinder breathing. Bruising may occur to the heart and cause an irregular heartbeat. Large vessels of the heart may be torn inside the chest, causing massive unseen bleeding. Air may collect between the lung tissue and the chest wall, known as a pneumothorax. A penetration or perforation of the integrity of the chest is called an open chest wound. If left untreated, shock and/or death will result. It is imperative that you assess the chest region every 5 minutes. Assessment should include DCAP BTLS, lung sounds, and chest rise and fall. Injuries to the abdomen. The abdomen contains vital organs that require a very high amount of blood flow to perform the functions necessary for life. The organs of the abdomen and retroperitoneum can be classified into 2 categories, solid and hollow. Solid organs include the liver, spleen, pancreas, and kidneys. Hollow organs include the stomach, large and small intestines, and urinary bladder. When injuries from trauma occur in this region of the body, serious and life-threatening problems may occur. Solid organs may tear, lacerate, or fracture, which can cause serious bleeding into the abdomen. Hollow organs may rupture and leak toxic digestive chemicals. The patient may develop a life-threatening infection. The rupture of a large blood vessels can cause serious unseen bleeding. Reassess the abdominal region using DCAP BTLS. Management of transport and destination. Call for ALS and helicopter assistance early to avoid delays in treatment and transport. Scene time. Survival of critically injured trauma patients is time dependent. Limit on-scene time to the minimum amount necessary to correct life-threatening injuries and package the patient. On-scene time for critically injured patients should be less than 10 minutes. The following criteria will help you identify a critically injured patient: dangerous MOI, decreased level of consciousness, any threats to airway, breathing, or circulation. Type of transport. Modes of transport ultimately come in one of 2 categories: ground or air. Ground EMS units are staffed by EMTs and paramedics. Air EMS units or critical care transport units are staffed by critical care nurses and paramedics. The Association of Air Medical Services, AAMS, and Medevac Foundation International identify the following criteria for appropriate use of emergency air medical services for trauma patients. There is an extended period required to assess or extract a remote or trapped patient. The distance to trauma center is more than 20 to 25 miles. The patient needs ALS care and there is no ALS level ground ambulance service available within a reasonable time frame. Traffic conditions or hospital availability make it unlikely that the patient will get to a trauma center via ground ambulance within the ideal time frame. There are multiple trauma patients who will overwhelm resources at the nearby trauma centers. EMS systems require bringing the patient to a nearest hospital rather than bypassing facilities to go directly to the trauma center. This may add delay to receiving definitive surgical care. There is a mass casualty incident. Destination selection. It is important for you to be familiar with how the American College of Surgeons Committee or trauma classifies trauma care. Trauma centers are classified into levels 1 through 4. Level 1 having the most resources. Level 1 facility generally serves large cities or heavily populated areas, provides every aspect of trauma care. Most Level 1 facilities are university-based teaching hospitals. Level 2 facility, located in less population-dense areas and provides initial definitive care. Level 3 facility provides assessment, resuscitation, emergency care, and stabilization. Transfers patient to a Level 1 or Level 2 facility when necessary. Level 4 facility, typically found in remote outlying areas where no higher level of care is available, provides advanced trauma life support, and transfers to a higher level trauma center. Trauma centers are characterized as either adult trauma centers or pediatric trauma centers, but not necessarily both. Pediatric trauma centers are not nearly as common. Do not make the mistake of transporting a pediatric patient to an adult trauma center when a pediatric trauma center is available. In 2001, the ACS-COT and the CDC published an updated field triage decision scheme. These criteria are intended to help pre-hospital care providers recognize injured patients who are likely to benefit from transport to a trauma center compared with transport to an emergency department. Special considerations. Remain calm, complete an organized assessment, correct life-threatening injuries, do no harm, never hesitate to contact ALS backup or medical control for guidance. Okay class, let's go over some review questions. Review question 1. Kinetic energy is a calculation of A. Weight and size, B. Weight and speed, C. Mass and weight, D. Speed and force. The correct answer is B. Kinetic energy is the calculation of mass, weight, and velocity, speed. Energy cannot be destroyed or only converted. Answer A. Weight is part of the formula, but size would also mean weight. Correct answer is B. Mass and weight are the same. Speed and force. Force is the product of mass times acceleration, all part of Newton's second law. Review question 2. A 20-year-old man has a major open facial injuries after his vehicle struck a tree head-on. Which of the following findings within the car would most likely explain his injury pattern? A. Deployed airbag, B. Bent steering wheel, C. Non-intact windshield, D. Crushed instrument panel. The correct answer is C. The mechanism of injury and condition of the vehicle's interior suggests likely areas of injury. Head and neck injuries are likely to result when the head and face impact the windshield. A. Deploying airbag. This typically results in abrasions of the face, head, and arms. Bent steering wheel typically indicates the presence of chest injuries. C is the correct answer. D. A crushed instrument panel. This typically indicates presence of leg and hip injuries. Review question 3. Which of the following would most likely result from the third collision in the three collision effect that occurs during a high-speed frontal impact motor vehicle crash? A. Extensive damage to the automobile. B. Flail chest and lower extremity fractures. C. Massive external trauma with severe bleeding. D. Aortic rupture or compression injury to the brain. The correct answer is D. During the third collision, the body's internal organs collide with the inside of the body. These injuries usually not as obvious, but are often the most life-threatening. Injuries that may result from this include internal injuries of the brain, compression injuries, and aortic tears resulting in massive internal bleeding. Answer A. This would occur in the first collision. Answer B would occur in the second collision. Answer C would occur in the second collision, and answer D is the correct answer. Review question 4. A young male experiences severe blunt chest trauma when his passenger car struck another vehicle head-on. During your inspection of the interior of his vehicle, you would most likely find A. Deployed airbags, B. Steering wheel deformity, C. Starring of the windshield, D. A crushed instrument panel. The correct answer is B. Blunt chest injuries during a motor vehicle crash typically occur when the chest impacts the steering wheel. Therefore, your inspection of the vehicle's interior will most likely reveal a deformed steering wheel. Answer A. Typically, this will cause abrasions of the face, head, and arms. Answer B is the correct answer. Answer C. Typically, this indicates the presence of head, face, and neck injuries. Answer D. This typically indicates the presence of leg and hip injuries. Review question 5. An unrestrained driver collides with a bridge pillar. Upon inspection of the interior of his vehicle, you note that the lower dashboard is crushed. During your assessment of the patient, you will most likely encounter A. Trauma to the pelvis, B. Blunt abdominal trauma, C. A severe closed head injury, D. Penetrating thoracic trauma. The correct answer is A. Impact points are often obvious from a quick inspection of the vehicle's interior. During a frontal collision, the unrestrained occupant's knees often impact the lower dashboard, with the type of impact energy is transferred from the knees to the femurs and into the pelvis or hip. Correct answer is A. Answer B, this usually is a result of striking the steering wheel. Answer C is usually a result of striking the windshield. And D, this is usually caused by flying debris, collisions with parts of the vehicle, or movable objects. Review question 6. Whiplash injuries are most common following blank impacts. A. Rear end, B. Rollover, C. Frontal, or D. Lateral. The correct answer is A. Whiplash injuries of the neck are common occurrence following rear-end collisions. As the vehicle is suddenly thrust forward, the opponent's head is thrust backward. Properly positioned headrest can minimize the severity of whiplash injuries. The correct answer is A. B. This typically causes life-threatening injuries. C. This typically causes chest, head, abdominal, and extremity injuries. D. You should suspect lateral chest and abdominal injuries on the side of impact as well as pelvic injuries. Review question 7. Death from a rollover motor vehicle crash is most often secondary to A. Crushing injuries, B. Airbag-related trauma, C. Multiple collisions to the interior of the car, D. Ejection of the patient from the motor vehicle. The correct answer is D. Rollover crashes are the most unpredictable with regard to injuries sustained by the patient. An unrestrained passenger may have struck multiple points within the vehicle. However, the most life-threatening event in a rollover is ejection or partial ejection of the patient from the vehicle. Answer A. These injuries occur during ejection or partial ejection. B. Airbags significantly reduce the risk of death in the motor vehicle crashes. C. This makes the prediction of injury patterns difficult, but it is not the most common life-threatening event in rollover. The correct answer is D. Review question 8. Severe abrasion injuries can occur when motorcycle riders are slowed after a collision by road drag. Road drag is most often associated with which type of motorcycle impact? A. Head-on collision, B. Angular collision, C. Ejection, or D. Controlled crash. The correct answer is C. During ejection, the rider will travel at high speed until stopped by a stationary object, another vehicle, or road drag. Severe abrasions and injuries, road rash, down to the bone can occur with drag. Answer A. Road drag can occur in a head-on collision, but is more often associated with ejection. B. Angular collision. Road drag can occur in an angular collision, but is more often associated with ejection. The correct answer is C. D. Controlled crash. Road drag can occur in a controlled crash, but is more often associated with ejection. Review question 9. When assessing a stab wound, it is important for the EMT to remember that A. Stabbings to an extremity are rarely associated with an exit wound. B. The majority of internal trauma will be near the path of the knife. C. Most stabbings are unintentional and can cause less severe internal injury. Answer D. More internal damage may be present than the external wound suggests. The correct answer is D. With low velocity penetrations, injuries are caused by sharp edges of the object moving through the body and are therefore close to the object's path. Weapons such as knives, however, may have been deliberately moved around internally, causing more internal damage than the external wound suggests. Answer A. The question did not state that the wound was to an extremity. B. This is true, but EMS providers must have a high index of suspicion for extended injuries due to movement. Answer C. Any stabbing that penetrates an individual's skin must be considered severe until ruled out by a hospital physician. The correct answer is D. Review question 10. A 40-year-old man was standing near a building when it exploded. He has multiple injuries, including a depressed skull fracture, severe burns, and impaled object in his abdomen. His head injury was most likely caused by blank blast injuries. A. Primary, B. Secondary, C. Tertiary, D. Quaternary. The answer is C. Primary blast injuries are caused by the pressure wave and include ruptured eardrums and hollow organ rupture. Secondary blast injuries are caused by flying debris and include impaled objects or shrapnel injuries. Tertiary blast injuries occur when the victim is thrown into a solid object, resulting in blunt trauma to virtually any part of the body. Quaternary blast injuries include other miscellaneous injuries. A. Primary. These injuries include damage to eardrums, lungs, and hollow organs. B. Secondary. These injuries are caused by flying debris and usually involve impalement. Answer C is correct. D. Quaternary. These injuries include burns, respiratory injuries, and crush injuries. This concludes the lecture on Chapter 24, Trauma Overview. Thank you for listening. If you have any questions or issues, please contact your instructor, and I will see you in the next chapter.